We go on to our next speaker, Dr. Subhashini Kaliyaparimal, who is the head of the Department of Glaucoma and Cataract and Refractive Services at JIPMER, Pondicherry, and she is going to talk on glaucoma drainage devices, a note for trainees and beginners.
Thank you, Madam. As Madam said, I would be talking on GDDs, a note for trainees and beginners. Gone are the days when glaucoma drainage devices were used as a last resort for refractory glaucomas. Nowadays, GDDs are used on par with trabeculectomies. This is mainly because of two reasons. There is enough evidence to show, especially there is this tube versus trab study, which has shown that tubes have comparable outcomes to trabs. And in fact, the cumulative probability of failure in the TVT study was only just 30% in the tube group and almost 50% in the trab group. And even the primary tube versus trab study has shown that the results of tubes are comparable to trabs. In India, the two commonly used devices are the Ahmed glaucoma valve and the Orolab aqueous drainage implant, or the RD. This has revolutionized glaucoma surgery since it became available in 2013. This is modeled on Burwell implant. As I said, the second reason GDDs have become popular is because of this availability of this low-cost device. It costs just 3,500 as compared to the actual Burwell implant, which costs almost 50 to 60,000, and it's only 1/5 of the cost of AGV. For the beginner or the trainee, it makes sense to use AGV in the initial few cases because the size of it is small. The area is around 184 millimeter square as compared to the RD implant, which is 350 millimeter square. And the other reason, of course, because it's a valved implant, there's no need for tube ligation or a ripcord suture. So I have divided the surgery into 8 important steps. The first is the conjunctival dissection, the conjunctival peritomy. I usually prefer at least 5 clock hours of conjunctival dissection. The recommended area where the first implant is placed is the supratemporal quadrant. So you need a good adequate dissection. You can even make some side cuts to have a good exposure, and then open up the area where you want the implant to sit. The second step is the muscle traction. At least for the beginner, it's better to take traction sutures of the superior rectus and the lateral rectus. And this is done using a 3/0 silk suture. You can see how the needle is passed reverse so as not to injure the sclera. The assistant can then pull these sutures, infranasally, these traction sutures, and you have a good exposure. The next step is priming. So once the GDD is out of the pack, then you have to prime where you inject fluid through a 30-gauge cannula and see for the flow to make sure there's no manufacturing defect. Then you can do the tube ligation. This step, some people do it after inserting the plate. So then again, you check the patency. So there should be, just make sure that there is no flow. The next step would be insertion of the plate. Here I'm using a RD implant. You insert, because it's a large one, the wings of these implant of the plate should go well behind the belly of the superior and the lateral rectus muscle. So just ensure that it's under the muscle so as to prevent migration of the implant as well as to prevent extraocular movement restriction. Then once you position the plate, then the next step would be to anchor the plate now. The anterior end of the plate should be around 10 millimeter, 8 to 10 millimeter from the limbus. So then with a 8-0 nylon, you can take a bite through the sclera, just like for scleral buckling. You should see the needle pass through the sclera. Then you pass it through the fenestration and suture it, and you need to bury the suture. That's important. Similarly, the other side also, you can take a bite through the same 8-0 nylon, and then one last time you just ensure that the wings of the plate are under the muscle. The next step is the tube insertion. So here you first mark 2.5 millimeter from the limbus, and that is the point where you are going to make the track and cauterize the area, and then you can cut adequate length of the tube. So at least 2 to 3 millimeter from the limbus, you can cut using the Westcott scissors beveled up. So this will help in ease of inserting the tube to the track, through the track. Then a paracentesis temporally. So this is to inject the viscoelastic. HPMC can be used, and here you basically want the iris to nicely go down, push it back, and then with the 23 gauge bent needle, you can make a track, and slowly just wriggle it into the chamber, ensuring that it's not so close, too close to the cornea or to the iris. So once you've made the track, you can inject some viscoelastic into the track and then insert the tube just with a McPherson. And once you have inserted—
You have 1 minute remaining, ma'am.
I'll just take 2 more minutes. The viscoelastic is then burped out, and then you have to anchor the tube so that it doesn't retract. This is done with a 10-0 nylon or 8-0 nylon. And then placing the scleral patch to cover it. Some people use the scleral, make a scleral tunnel itself. So for the beginner, it would be good to use a scleral patch graft to cover the tube to prevent tube eroding through the conjunctiva. Then the next step, the final step, is the conjunctival suturing. So here again, you need to be as careful as for a trap. Handling is important. Any buttonholes you will have to suture, and you have to ensure that there is no leak, because here also there is a bleb which forms over the plate. So the instruments and suture materials are nothing special. So just ensure that you have a 23 gauge needle and muscle hooks. Suture materials are, as you have seen in the video, it's 3-0 silk for the traction sutures, 8-0 nylon for anchoring the plate, 6-0 or 7-0 for the ligature, patch graft, and conjunctival suturing, or you can even use fibrin glue, and 10-0 nylon for anchoring the tube. In case you a ripcord suture you're using, it can be used in a very advanced glaucoma with high pre-op IOP. So here you can see a 5-0 proline I'm using. It has to go from the plate side, and then you pass it under the conjunctiva, and it comes out inferiorly. You can cut the remaining suture, and a small bit remains there. In the post-op period, you can just pull it in case the pressures are very high. Post-op management is with topical antibiotics and steroids for 6 weeks, and anti-glaucoma medications you will have to continue for 3 to 6 weeks if a non-valved GDD is used. So complications, hypertony-related complications, tube exposure, extraocular muscle restrictions do occur, but these are part and parcel of any surgery. To conclude, GDD can be the first line of management in certain cases. So it is better to be familiar with the use of GDD. If you can do a good trab, you can also do a good glaucoma drainage device implantation too. Thank you.
Excellent, truly excellent teaching video, Dr. Subashini, but I'm sorry, I'll have to hold back on the questions.